Welcome back to the deep dive. Today, we're looking into something that, well, it really highlights how even the strongest animals can have these hidden vulnerabilities. You picture a horse, right? Powerful, graceful. It's magnificent. But even they aren't immune to serious threats impacting their most vital organs, often unseen. So our mission today is to delve into equine infective endocarditis. It's a really serious, sometimes kind of mysterious heart condition in horses. We've gathered the latest understanding, the research to really walk you through it. By the end, you should have a solid grasp of what it is, how it starts, the subtle signs, diagnosis, treatment, the whole picture. But, without getting bogged down.
Exactly. It's a complex one, definitely challenging for owners, for vets too, and it really is life-threatening for the horse.
Okay, so let's start right at the beginning. To really get it, what is equine infective endocarditis, fundamentally?
Fundamentally, it's an infection. It settles on the inner lining of the heart, the endocardium. Usually it's bacteria doing the infecting, but very rarely it could be fungal.
Fungal.
And most often it targets the heart valve specifically.
The valves. Okay. And how does this actually, get started? Doesn't just appear, does it?
No, there's a sequence. It usually kicks off when that inner heart lining, the endocardium, has some kind of existing damage, maybe just a rough spot. This exposes collagen, which is sort of sticky for blood components. So you get this little clot-forming platelets, fibrin, the usual stuff.
Like a tiny scab almost, but inside the heart.
Sort of, yeah.
Yeah.
And then if the horse has bacteria, or sometimes fungi circulating in its bloodstream that's bacteremia, those microbes find this little clot. They latch on, start to multiply, and build up this vegetative mass. It's basically a growing clump of fibrin platelets and the bacteria or fungi themselves right there on the valve.
Wow, so it's like this little infectious colony setting up shop. That's pretty concerning. Where in the heart does this usually happen?
The mitral valve is the most common spot. After that, the aortic valve.
Okay.
The tricuspid valve can also be involved, and that's often linked to septic jugular vein thrombophlebitis.
Septic jugular vein thrombophlebitis. Right, you mentioned that. Let's break that down. Septic infected. Jugular vein, big neck vein. Thrombophlebitis, inflamed vein with a clot. So an infected clot in the neck vein. Okay, we'll definitely circle back to why that's important for prevention. But first, how common is this overall? Is it something vets see often?
No. It's considered uncommon. Definitely not rare, but not common. And what's really interesting, maybe a bit surprising, is the age group it affects most.
Oh.
Horses under 3 years old, they actually make up the majority of cases.
Under 3. Wow, so not older horses with wear and tear, necessarily.
It can happen at any age, but yeah, younger horses are disproportionately affected, which really shifts your focus, if you're dealing with young stock. You need that higher index of suspicion. There's no specific breed or sex that seems more prone to it, though.
Okay, so uncommon, but hits younger horses harder. That rarity probably makes diagnosis tougher, too, doesn't it? Not the first thing you'd jump to.
Exactly. It requires vigilance.
So let's dig into the why, the pathophysiology. You said bacteria in the blood is the key.
Absolutely key. The whole process almost always hinges on bacteria getting into the bloodstream somehow. Where those bacteria come from is the next big question.
Right. Where do they come from? What lets them into the system to reach the heart?
Well, the most frequent culprit, as we touched on, is that septic thrombophlebitis, particularly in the jugular vein.
From 5E catheters, injections.
Yeah, exactly. Indwelling catheters are a big risk factor, but also repeated injections, even just routine blood draws if things get contaminated, the vein gets irritated. And that source often leads to endocarditis on the tricuspid valve, specifically.
Okay.
But bacteria can sneak in from lots of other places, too. The GI tract is a possibility. Think severe colitis or enteritis. The respiratory tract, like pneumonia, UTIs, urinary tract infections, even the musculoskeletal system. Things like septic arthritis, bone infections, deep abscesses somewhere.
So joint infections, things like that.
Yes. And in foals, you worry about umbilical infections. Even dental disease, though that's considered wear as a source.
That's a huge range of possibilities. It sounds like basically any significant infection anywhere in the horse's body could potentially set the stage if bacteria spill into the blood.
That's a good way to put it, yes. And while bacteria can sometimes stick to healthy valves, it's much, much easier for them if there's some pre-existing damage. Like a congenital defect that the horse was born with, or just chronic wear and tear over time.
Yeah.
Even turbulent blood flow can create these little rough patches. They call them jet lesions. That gives the bacteria something to grab onto.
And the mitral and aortic valves being most common, That's because of the higher pressure on the left side of the heart.
That's the thinking, yeah. More pressure, more turbulence, potentially more microscopic damage over time, making them more susceptible.
Makes sense. So once these vegetations, these growths are there, they mess with the valve function, usually causing leakage, right? Regurgitation.
Yes, that's the most common outcome. Valvular insufficiency or regurgitation. The valve doesn't close properly, so blood leaks backward.
And that backflow is what causes the heart murmur you might hear.
Typically, yes. That turbulent, leaky flow creates the sound. Less often, the vegetation might actually obstruct the valve opening, causing stenosis or narrowing.
Okay, so problems right at the valve. But it doesn't stop there, does it? This is where it gets really systemic and complicated. The infection doesn't stay contained in the heart.
No, absolutely not. And this is critically important. Bits of that infected vegetation can break off. They're called septic emboli.
Septic emboli, like little infected clots traveling around.
Exactly. Tiny infected missiles launched into the bloodstream. And they can lodge anywhere.
Oh, wow. Where do they tend to end up?
Common targets are the kidneys, the lungs. The joints are a big one.
Yeah.
That can cause that shifting leg lameness we sometimes see.
Ah, that makes sense now. Shifting lameness from infected emboli in different joints.
Precisely. They can also go to the brain, causing neurological problems or even lodge in the heart muscle itself, the myocardium. These emboli can cause new abscesses wherever they land or infarcts areas of tissue death because the blood supply got blocked.
So it spreads infection and blocks blood flow. Nasty combination.
Very nasty. And beyond the direct emboli, the horse's own immune system can cause trouble too.
How so?
You get these circulating immune complexes, basically clumps of antibodies stuck to bacterial bits. These can get filtered out and deposited in places like the kidneys or joints. And that deposition triggers inflammation. So you get immune-mediated damage on top of everything else.
Okay. And all this time, the heart valve itself is getting more damaged.
Right. As the vegetation grows or causes more valve destruction, the heart's ability to pump efficiently declines. And that can lead to congestive heart failure, CHF.
Which manifests differently depending on which side of the heart is failing.
Correct. If it's left-sided failure, usually from mitral or aortic valve problems, you get fluid backing up into the lungs, pulmonary edema. That causes respiratory signs like coughing or difficulty breathing.
And right-sided. From the tricuspid or maybe pulmonic valve.
Then you see fluid back up in the body. Things like jugular distension, those big neck veins bulging, and peripheral edema, swelling in the legs or belly.
So it starts in the heart but ends up affecting, well, potentially everything. Respiratory, nervous system, kidneys, liver, GI tract, muscles, joints.
It can become a whole body crisis, yes.
Which I imagine makes spotting it early really difficult. The signs must be all over the place.
They often are. Diagnosis is challenging. The onset can be really slow and sneaky, insidious, and many of the early signs are very nonspecific. Vets need a high index of suspicion. You have to think of it, or you might miss it.
So what are those signs? Walk us through what an owner or a vet might see, from the vague stuff to the more specific clues.
Okay, so general nonspecific signs would be things like fever. Often a fever that comes and goes or just persists without an obvious cause.
Fever of unknown origin.
Exactly. Lethargy, depression, not wanting to eat, weight loss, poor performance if it's an athletic horse, maybe just general muscle weakness. Pretty vague stuff.
Right. Could be anything.
Could have many things.
Yeah.
But then you might see more distinctive signs. Shifting leg lameness, like we discussed, swelling in a joint or a tendon sheath that doesn't have an obvious injury cause, and jugular thrombosis, that clotted, infected neck vein. Those should definitely raise a red flag.
And the heart murmur, how reliable is that?
It's crucial. A heart murmur is found in most cases, maybe 70 to 90%. But the key is often a new murmur, or a murmur that changes in character, especially if it's diastolic heard when the heart relaxes.
So listening regularly is important.
Very. A changing murmur, particularly diastolic, in a horse that's systemically unwell. That dramatically increases suspicion for endocarditis. But you have to remember, a murmur might not be there in the very early stages, or sometimes with right-sided lesions, they can be harder to hear.
Okay. And other signs related to heart failure might pop up too, like weight loss, coughing, breathing fast.
Yes, those can develop as this valve damage progresses. So you look at the whole picture, the fever, the lethargy, maybe the lameness, and a new or changing heart murmur. That combination really points towards endocarditis.
Got it. So if you suspect it, how do you confirm? What are the go-to diagnostic tools?
The absolute gold standard for imaging is echocardiography. cardiac ultrasound.
Echo. Okay. What does that show you?
It lets you see the heart directly. You can visualize those vegetations on the valves, see how big they are, where they are, what they look like. You can use Doppler with the echo to see the blood flow, document that leaky regurgitation, see how severe it is, and you can assess the overall size and function of the heart chambers. Look for signs of CHF.
Can it always see the vegetations?
Usually, but very small ones, or ones tucked away in the atria, can sometimes be tricky to spot with the standard transthoracic approach, where you scan from the chest wall. But it's still the best imaging tool we have.
And what about blood tests? You mentioned bacteremia is key. Blood cultures.
Blood cultures are absolutely critical. They're essential for a definitive diagnosis and, crucially, for guiding antibiotic choices.
How do you make sure you get a good sample?
Technique is vital. You don't just take one sample. You need to take multiple, typically 3 to 5 serial samples.
3 to 5, wow.
Yeah, from different sites if possible, like both jugular veins, over maybe a 24-hour period. Or try to time them with temperature spikes when bacteria are more likely to be circulating in high numbers.
And timing relative to antibiotics is important too, right?
Hugely important. You must collect those culture samples before starting any antimicrobial treatment.
Why is that?
Because even one dose of antibiotics can kill off the bacteria in the bloodstream or reduce their numbers enough that the culture comes back negative, even if the horse does have endocarditis.
So get the cultures first, then start treatment.
Exactly. But even doing everything right, blood cultures can still be negative in a significant number of cases, maybe 30 to 50%. Could be the bacteria aren't shedding constantly or they're deep in the vegetation. But if you do get a positive culture, it's highly diagnostic and tells you what bug you're fighting.
Okay. What other lab work helps? CBC, chemistry panels?
Yeah, they provide supporting evidence. You often see signs of chronic inflammation on a CBC and chem panel. Things like high white blood cell counts, specifically neutrophils. High inflammatory markers like SAA, serum amyloid A, or fibrinogen. Often high globulins, too. Anemia is common.
And kidney values.
BUN and creatinine might be elevated if the kidneys are taking a hit from emboli or just poor blood flow due to the heart failure.
Anything else?
We can measure cardiac troponin I. If that's elevated, it suggests the heart muscle itself is being damaged. And a urinalysis might show protein or blood if there's been embolization to the kidneys.
So you piece all this together, the clinical signs, the echo findings, the blood cultures, the other lab work.
Exactly. And you also have to rule out other things that might look similar, like pericarditis inflammation of the sac around the heart, or myocarditis inflammation of the heart muscle itself, or even just age-related degenerative valve disease, which causes murmurs but isn't infectious.
How do you tell those apart?
The echo is key for differentiating structural issues. The presence of vegetations points strongly to endocarditis. The clinical signs, the fever, the inflammatory markers, positive blood cultures, those all help distinguish it from non-infectious valve disease or other causes of fever.
Right. Okay, so once you've got the diagnosis, or at least a very strong suspicion, what's the battle plan? How do you treat this?
Treatment has 2 main goals. 1, kill the infection, sterilize those vegetations. 2, support the cardiovascular system.
And I'm guessing it's not simple or quick.
No, definitely not. Treatment is aggressive. It's prolonged. We're talking weeks to months of antibiotics, usually 4 to 8 weeks at a minimum, often longer, and it can get very expensive. Hospitalization is usually required.
Okay, so cornerstone is antibiotics.
Absolutely. That's the main weapon.
Yeah.
Because it's so serious, you start immediately, even before culture results are back. You use broad spectrum, potent bactericidal, meaning bacteria-killing antibiotics given intravenously.
Like what combination?
A common starting point is penicillin combined with an aminoglycoside like gentamicin. That covers a lot of the likely bacteria. But you have to be really careful with aminoglycosides like gentamicin. Monitor kidney function closely because they can be toxic to the kidneys.
Right. And then you adjust based on the cultures.
Yes. Once, if you get culture insensitivity results, you tailor the antibiotic choice to the specific organism that grew and what drugs it's susceptible to. That gives you the best shot. There's also some thought that certain antibiotics, like enofloxacin, might penetrate into those vegetations better. And sometimes rifampin is added because it's also known for good penetration into tissues and abscesses.
And how do you know if it's working?
You monitor closely, repeat blood cultures periodically to see if you've cleared the bacteremia, track the inflammatory markers on CBCs, you want to see those coming down, and repeat echocardiograms to see if the vegetations are shrinking or stabilizing, and assess heart function. It's an ongoing process.
Makes sense. What about supportive care beyond antibiotics? You mentioned platelet stickiness earlier. Aspirin.
Yeah, antiplatelet therapy is sometimes used, aspirin or clopidogrel. The idea is to make platelets less sticky, maybe help prevent the vegetation from growing larger, or reduce the risk of emboli breaking off.
Does it work?
The evidence for its routine use and clear benefit isn't super strong. And there are potential risks, like bleeding, so it's a bit debated. Some clinicians use it, some don't. It's often a case-by-case decision.
Okay. And what if the horse is already in heart failure?
Managing the CHF is absolutely critical for survival. That involves standard heart failure medications.
Diuretics.
Yes, diuretics like furosemide or Lasix to get rid of excess fluid. Vasodilators like ACE inhibitors, drugs like benazepril or quinapril to make it easier for the heart to pump blood forward.
What about drugs to help the heart muscle pump stronger?
Sometimes, yes. Positive inotropes like pimobendan or, less commonly now, digoxin might be used if the heart muscle contractility is really poor. But they have to be used carefully and based on specific indications from the echo and clinical picture.
And activity level during all this? Strict rest.
Pretty much. Stall rest is crucial during the active treatment phase. Maybe some gentle hand walking, but that's it. Minimize stress on the heart.
And after treatment, if they achieve a cure,
Once the infection is cleared, bacteriologic cure, then gradual turnout into a small paddock might be appropriate. But returning to athletic work, that depends entirely on how much permanent damage the valve sustained.
so some horses might never be rideable again?
Unfortunately, yes. If there's significant residual valve leakage, or if they develop dangerous heart rhythm problems like ventricular arrhythmias, or if the pulmonary artery becomes dilated, they're generally considered unsafe to ride due to the risk of collapse or sudden death during exercise.
That's tough. And owner education sounds vital throughout this whole long process.
Absolutely critical. Owners need to be partners in monitoring. Daily temperature checks, especially late afternoon or evening when fevers often spike. Watching for any subtle changes, exercise intolerance, faster breathing, coughing, filling in the legs or belly, longer recovery time after minimal exertion. Any changes in heart rhythm felt when checking the pulse should prompt an ECG. Vigilance is key.
Okay. So after all that intensive, lengthy, expensive treatment,
Yeah.
what's the bottom line? What's the prognosis really like for these horses?
This is the really sobering part. The prognosis is generally considered guarded to poor. Even with the best care, this condition is often fatal. It's a really tough disease to beat.
Guarded to poor. That's not optimistic. Are there factors that make it even worse?
Yes, several things point towards a poor outcome.
Which valve is affected matters a lot. Aortic valve endocarditis generally carries the worst prognosis.
Why the aortic?
It's under such high pressure, and dysfunction there impacts systemic blood flow so critically. Mitral valve disease also has a guarded prognosis. Tricuspid valve endocarditis may be slightly better if caught very early, especially if linked to a treatable jugular vein issue, but still very serious.
Lord help.
The extent of the damage is huge. Large vegetations, really severe valve leakage, or signs of significant congestive heart failure right at the time of diagnosis. Those are all bad signs.
And the evidence of septic emboli spreading to critical organs. Brain, kidneys, multiple joints. That definitely worsens the prognosis significantly. And of course, if you can't identify the bacteria causing it or if it's resistant to antibiotics, that makes successful treatment much harder.
So survival rates overall are quite low then.
Yes, they are low. And achieving a true long-term cure where the horse returns to full health and function is rare.
Even if they survive the infection itself.
Even if they achieve bacteriologic cure, meaning the infection is gone, they're often left with significant permanent damage to the heart valve. That residual valve insufficiency, the leakage, often tends to get worse over time, even without active infection. So it can shorten their useful performance life, if they had one, and ultimately shorten their overall life expectancy. Continued heart failure management is often needed.
Wow. That really underscores the need for incredibly early diagnosis and intervention, doesn't it?
Absolutely. The best chance, and it's still only a guarded chance, comes with catching it early and hitting it hard with aggressive treatment before there's extensive irreversible valve damage or widespread systemic complications like emboli or severe CHF. Time is absolutely critical.
Okay. And finally, prevention. Is there anything that can be done to prevent this devastating disease?
Given the strong link particularly for tricuspid valve endocarditis. The single most important preventative measure we can point to is really aggressive and prompt treatment of septic jugular vein thrombophlebitis.
So managing catheter sites meticulously, treating any jugular vein issues immediately.
Exactly. Minimize the chance of that becoming a source of bacteria seeding the heart. More broadly, it just highlights the importance of managing any potential source of bacteremia, any significant infection, promptly and thoroughly in horses.
Well, that was certainly a deep dive into equine infective endocarditis. We've gone from defining this really complex condition, understanding how those vegetations form, to its often sneaky nature, the diagnostic hurdles, the tough treatment road, and ultimately, its pretty grim prognosis.
Yeah, we've really seen how important it is to recognize those subtle signs, maybe piece them together, how vital tools like echo and blood cultures are, and just how challenging but necessary that aggressive long-term treatment is.
So here's a final thought for you to consider. Given how severe and often fatal this disease is, even with all our advanced veterinary medicine, what does that tell us about the incredibly delicate balance within these complex biological systems like a horse's body? And maybe how might appreciating these vulnerabilities influence how we approach preventative care and maybe rapid intervention, not just in horses, but really in any species? Something to think about. Thanks for joining us on the Deep Dive.